illness. He doesn't have any history of rash, joint pains, fever, jaundice, and chronic cough. No history of heat intolerance, palpitations, or excessive sweating. No history of food intolerance, and no history of recent travel. For above mentioned complaints, patient had multiple hospital admissions and was treated with IV fluids and antibiotics. Patient was investigated with baseline blood test, imaging, colonoscopy, and upper GI endoscopy, which was normal according to the patient. Coming to the past history, patient doesn't have any history of diabetes, thyroid, hypertension, or TB. No significant past surgical history. Personal history: he consumes mixed diet, bladder regular, sleep disturbed due to nocturnal diarrheal episodes, and he is a known alcoholic since 15 years, 19 ml per day, 2 to 3 times a week. And he is non-smoker. Coming to the family history, mother died of TB 5 years ago. Grandfather has history of colon cancer, and his uncle had a history of leukemia. Nutritional history: requirement is 2,400 calories and consumption 1,300 calories. Deficit is 1,100. Coming to the summary, 34-year-old gentleman from Thrissur with no known comorbidities, known alcoholic, presented with complaints of large volume, non-bloody diarrhea of 8 months duration, with history of nocturnal episodes and associated periumbilical colicky abdominal pain, with history of significant weight loss, anorexia, and pedal edema, with features of malabsorption.
Okay, so you are presenting a case of diarrhea. Can you define diarrhea?
Sir, increase in stool frequency of more than 3 times per day.
Okay, then?
Or more than 200 grams per day. Based on stool weight.
What about the fluidity?
Fluidity will also be increased.
Increase. So according to the Bristol Myers, it will be?
It will be type 6 to 7. Sir.
Yeah, 5 to 7. Okay. So stool weight more than, usually what is the Indian, the Western standards is 200 grams. Any idea about the Indian stool weight?
300, sir.
Yeah, it will be more because we are taking more fiber rich diet. So why do you say it's a chronic diarrhea?
Duration, sir, it is of 8 months duration. Any diarrhea of more than 4 weeks is chronic.
If there is a alteration in the bowel habits, in the sense there is diarrhea with constipation, what are your differential diagnosis?
Diarrhea with constipation.
If you did not understand the question, you can always say that.
Yeah, diarrhea with constipation.
Spurious diarrhea can happen.
Yeah, it can be overflow incontinence. So in case of functional bowel disease, you can have diarrhea alternating with constipation, and then also in case of intestinal tuberculosis. Yes. And in colonic malignancy. So this also you should always keep in mind when you're discussing about diarrhea. So constipation association and then differential diagnosis should be in your back of mind. So do you think it's an organic diarrhea? So whenever the approach to diarrhea, first we have to identify whether this is an organic diarrhea or a functional diarrhea. So how will you differentiate this to organic with a functional diarrhea?
Organic diarrhea, there will be nocturnal episodes. Yeah. And the duration will also be long in organic diarrhea.
Yeah, duration will be long. Anything else?
Constitution, a loss of appetite, loss of weight will be present in organic diarrhea.
What about the onset of diarrhea? Any difference in organic versus functional? Functional, it will be insidious onset. Okay, whereas in organic, usually it will be acute onset of illness. Usually, insidious onset. No, so suppose you take a irritable bowel syndrome, they will have a long history. No, so and onset also is insidious onset. Okay. And then if there is a history of dehydration, hypokalemia, it indicates an organic or a functional.
Organic.
Yeah. So first you have to identify. So do you think this is organic diarrhea?
Yes.
Okay. And now, is it a small bowel diarrhea or a large bowel diarrhea?
Sir, according to history, it is mostly
Louder, please. Louder. Dr. Deepthi,
mostly it
louder,
is
please.
small bowel. Mostly it is
Be
small
confident.
area.
See, be confident and answer confidently.
Hello? Yes, it is small bowel areas. Because patient is having large volume.
Yeah, it's large volume. And then
Associated with borborygmy, bloating.
okay.
And frequency, sir, low frequency. Frequency was less. And he doesn't have any blood in stool.
Yeah, blood in stool. Good. Then if
no
there is
urgency or tenesmus.
Yeah, rectal involvement. So the important symptoms will be tenesmus and urgency.
Rather means lack of colorectal symptoms.
Okay.
Okay, and presence of a large volume diarrhea. Of course, if there is a small bowel type of pain associated with that, you may think it is small bowel. Plus if there's a chronic diarrhea with the features of malabsorption.
Yeah, malabsorption. So,
okay, like for example, nutritional deficiency, weight loss. Weight loss can occur for chronic large bowel and small bowel, but more common for small bowel. But malabsorption features if present, I think that will be extremely highly suggestive of a small bowel diarrhea. Okay.
Vitamin
now, in
D.
this case,
Yeah.
May I interrupt for a moment, Professor Shine?
Yes,
in
sir,
this case, were there any features of nutritional deficiency in the history?
Yes, sir. Patient is complaining of pedal edema.
Pedal edema. So, what do you think it is
macronutrient due to low albumin.
Low albumin due to low food intake or due to something else?
Due to loss, protein loss, maybe because
protein loss. So if you think there's a protein loss, there has to be causes which produce protein loss. So you are already committed. Okay. It has to be either mucosal ulcerations or exudation of pus or similar substances or lymph from the surface of the mucosa, either from the small intestine or large intestine. Okay. So that is protein losing enteropathy or colopathy. Okay. Any other nutritional deficiency?
He is complaining of altered taste.
Altered taste.
What
So what do you think it is due to?
Zinc deficiency, micronutrient deficiencies.
Okay. Most of the patient with a malabsorption can have glossitis. That's a very common thing. Plus zinc deficiency. Okay. Professor Shine, over to you.
Yeah. So before investigating a patient, you have to take a proper history. So you have to remember these 4 I's: incontinence, iatrogenic, infection, and IBSD. So if you go according to this 4 I's, so first is incontinence. So how will you differentiate between incontinence? Because it's very important to differentiate. So how will you differentiate incontinence from diarrhea? So there will be absence of rectal urgency or loose stools. Okay. When there is no urgency or absence of rectal urgency or there is no loose stools, so you'll have to think in terms of incontinence. What are the 3 types of incontinence you know?
Overflow.
Yeah, overflow incontinence. That is a fecal seepage. Okay. And then passive incontinence. What is passive incontinence? When because of the discharge of the fecal matter or flatus without the awareness of the patient. Okay. That is passive incontinence. What is urge incontinence? Urge means when they get the urge, then they cannot control it. That is urge incontinence. So we should know so always try differentiate between, because sometimes incontinence can also present and severe diarrhea.
Have some examples also so that the students will understand it easily. I think acute proctitis or ulcerative colitis, the classical thing is urge incontinence. No, they have the urge, and before they reach the toilet, they may pass a little bit. A person with a neuromuscular paralysis obviously will not know, for poor control of the sphincters, and by the time the colonic pressure increases, they may have incontinence without their knowledge, or they have no control over it. And the earlier one, I think you have told spurious diarrhea produced by overflow incontinence. I think these are the 3 examples of these conditions.
Yeah. Now, one word about fecal urgency. In ulcerative colitis, we all know that the patient is having urgency, but I think this is a neglected symptom. And but the most important symptom for the patient is actually urgency. So now there is a fecal urgency response scale also. Have you heard about it?
No.
We can quantify the urgency actually by there is actually a fecal urgency response scale is available now. So if you ask the patient the time which is taken for the patient to, he can hold the stool. If he can hold the stool for approximately 15 minutes, then it is actually normal. But if it's mild, means he can hold up within 5 to 15 minutes. But moderate means the patient is not able to hold within 2 to 5 minutes. And too severe means patient is not able to, he is unable to make it to the bathroom. So I think this symptom is actually the fecal urgency response scale. This is actually very, very easy if you follow this, and we can identify patients, ulcerative colitis patients with fecal urgency. And the importance of what is this importance is we have new drugs coming up for the treatment of urgency in ulcerative colitis. A new biological is also is coming up. So this is very important to identify this fecal urgency in patients with ulcerative colitis. When you didn't mention about drug history. Before that, any comments from Jayanti madam?
I have asked those questions in the chat box, I think.
Jayanti ma'am's questions are, one is the drug history, then history of high-risk behavior, history of joint pains, and then whether it is osmotic or secretory diarrhea, so the mucus was present. These are the questions asked. So Dr. Deepthi, you can highlight on it and also tell us the relevance of these questions.
Yeah, drug history. First, you can talk about drug history.
You can look at the chat box also.
Patient. Yes, sir. Patient doesn't have any significant drug history, sir. Only patient got some antibiotics.
What drugs did you ask?
Any?
When you say drugs, when we ask specific questions, which are the drugs that can cause watery diarrhea?
Madam, diabetic medications like
which
diabetic? You heard of autonomic enteropathy? Yeah.
Which is the most common drug which can produce diarrhea?
Autoimmune enteropathy. Have you heard of autoimmune enteropathy?
There are many patients who do not know that they are taking laxatives and they continue to take it and complain that they are having diarrhea. This is very common. See, for example, when they take antacids, very many patients have. The patient may be given laxative by the doctor, but without telling that it is a laxative. Then they will keep on taking it or even increase the dose and develop diarrhea. Some people may take it for constipation, but at the same time complain of diarrhea because they expect a normal bowel movement and not a diarrheic bowel movement. Because patient always want a normal defecation. No, we can only produce a diarrheic defecation by giving drugs. Then fictitious or factitious diarrhea, wherein patient will take it surreptitiously and will not tell us the story, and then we will investigate for chronic diarrhea. So these are straightforward laxatives. But apart from that, there are many drugs which are used in day-to-day clinical practice which can produce diarrhea as a side effect.
Yes.
In fact, I will tell you, in my pharmacology professor used to say that tell us the side effect of the diarrhea, tell us the side effect of a drug without nausea, vomiting, diarrhea. I don't want these three side effects. So thinking that these are common side effects of many drugs, no? So tell us the important drugs which can produce diarrhea.
Can you start with the anti-diabetic drugs which can cause diarrhea?
Metformin, sir.
Yeah, metformin. Good. Then acarbose. Okay, and also gliptins. Newer gliptins are also can produce. Metformin, can it produce any other malabsorption of any nutrients? Micronutrients.
Vitamin B12. Sir.
Why should it produce? How it is producing vitamin B12 deficiency?
Mechanism.
Yeah, actually the cobalamin protein will combine with the salivary haptoporin. So the salivary haptoporin has to bind with the cobalamin. In the so if you give metformin, what happens? This combination will not happen. And then subsequently it binds to the intensive factor. So it inhibits the binding of the cobalamin protein to salivary haptocorin. Okay, that is why it produces vitamin B12 deficiency. What can you just briefly tell how these drugs produce diarrhea mechanism? One is they can directly cause toxicity to the mucosa. Okay, and any other way by which they can cause the side effects? The next is the inhibition of the mucosal enzymes. They can inhibit the enzymes. Okay, and one more the way by which they will bind with the micellar components, so that the micelle formation will be affected. So these are the multiple mechanisms by which a drug can inhibit, that can cause diarrhea. Okay.
Antibiotics are notorious to produce diarrhea, no?
Which antibiotic?
Amoxicillin, clindamycin.
Which chemotherapeutic drug is well known to produce?
Not.
Mycophenolate mofetil. You should be aware of it, because you'll be seeing a lot of patients on with this drug, which can cause diarrhea, and then methotrexate. Okay, and then any antihypertensive drug which is commonly used. Yeah, olmesartan. Olmesartan can produce. It can produce a sprue-like enteropathy. Any monoclonal antibody which is being used, which can cause, because these are all common side effects. That is why specifically we are asking. Ipilimumab. And then the newer immune checkpoint inhibitors like nivolumab. Okay, and then interferons. So these are the drugs, you should be, when you, especially mycophenolate mofetil, and they are very common. They can produce colitis, and you have to identify it when the patient comes to you with diarrhea. Any hard drug for the HIV which can produce a diarrhea, these are all common drugs, common causes of diarrhea actually.
Deepti, can alcohol produce diarrhea? Alcohol?
Yes, sir.
He has been taking alcohol for a long time.
Yes.
Any mechanism?
This particular topic can come as an exam topic also. Drugs and diarrhea, or drug causing diarrhea, or drugs and malabsorption. Like that it can come. So I think all the pages have to update the knowledge on the side effect of common drugs. There are a couple of articles in the net. We'll try to download it and give it to you.
The question sir was asking is, can alcohol produce malabsorption?
And diarrhea.
Yeah, and diarrhea.
Yes.
There are two questions. Can alcohol produce diarrhea? Can alcohol produce malabsorption? Chronic alcohol
can produce diarrhea, sir, but
Louder, louder.
Alcohol can produce diarrhea, sir.
Okay.
Malabsorption.
It can cause malabsorption of several vitamins actually.
That can produce an enteropathy also, alcohol. And
yeah, alcohol can produce mucosal damage to the enterocytes, and though it is not clinically very evident, but if you do the test, you may find some evidence of malabsorption, though it may not manifest clinically. Is there any indirect method by which alcohol can produce malabsorption? Malabsorption like picture or steatorrhea? This is very common. Alcohol induced chronic pancreatitis. Okay. Yeah. So when we slightly shift to theory side, we may ask many questions. Okay, but most of the examination will still stick to the case, but try to test your knowledge around the case, around the symptoms. Okay.
And there was a question in chat box. No, how will you? What is the history for a neuroendocrine tumor?
Flushing.
Yeah.
History of any flushing.
Usually it will be. Usually either it is due to increased motility or due to a secretory type of diarrhea. Okay, so which is the secretory type of neuroendocrine tumor induced diarrhea?
Carcinoids.
Okay, carcinoid can produce. Then medullary carcinoma of the thyroid.
Thyroid,
Okay. MCT. Okay.
Okay.
Calcitonin-like substances. Then, what is pancreatic cholera? VAPoma. Okay. It is called watery diarrhea, like that, no? Hypokalemia, hypohydria. So, Werner Morrison syndrome, I think it's the name. VAPoma tend to produce severe secretory diarrhea. Okay. Then, associated phenomena like in carcinoid with flushing and pigmentation and other things also we may have some clues.
About we were asking about heart and diarrhea, no? These protease inhibitors are well known to produce diarrhea. The classical example is saquinavir, and now we have the nelfinavir. So these drugs, when patients on heart comes with diarrhea, we have to think about drug-induced diarrhea also. And then how will you diagnose IBS, the diarrhea predominant irritable bowel syndrome? How will you diagnose? What is the Manning's criteria?
Manning's
Or Rome 4 criteria?
Yes, Rome 4.
Manning's is the original criteria, which has been subsequently modified into Rome. And currently, which Rome you have? Which Rome 1, 2, 3?
Rome 4, sir.
Rome 4.
Okay.
Rome 4.
Fine.
And there is one difference between Manning criteria and the Rome's 4 criteria is they removed this abdominal distension. And there are a lot of publications by Ghoshal sir and all saying that Manning's criteria is better than Rome's criteria because this abdominal distension is removed from it actually. Okay, what is Rome's criteria? Do you remember?
It's the presence of abdominal pain of more than 6 months and associated with
Change in frequency of stool,
frequency of stool.
pain relieved by defecation. Okay, so you should be aware of Rome 4 criteria. Okay. So
and most importantly, absence of red flag signs and symptoms.
yes.
Okay.
So from this history, do you think it is an inflammatory diarrhea, a fatty diarrhea, or a watery diarrhea?
According to history, watery diarrhea.
Okay.
Sorry, he has mucus also, sir. Inflammatory diarrhea.
Inflammatory diarrhea does not necessarily mean there is mucus, because in irritable bowel syndrome, technically there is no much of inflammation and mucus may be present. And in Miller's adenoma of the rectum, mucus will be present copiously. In solitary rectal ulcer syndrome, even if there is no ulcer, even if there is no active inflammation, there can be copious mucus. Okay, so this condition, mucus will be there. So inflammatory diarrhea by and large is actually after a lab evaluation, or in acute diarrhea, it should have features of an acute infection like a fever, prostration, and other things by which we can clinically say that this is an acute inflammatory diarrhea. But in chronic diarrhea, it will be very difficult to say whether it is inflammatory from clinical picture. So we'll have to do stool microscopy and find out. But by and large, this inflammatory diarrhea is mostly to differentiate between non-inflammatory diarrhea in acute diarrhea and perhaps whether to give antibiotics or not. Okay, that is it. So one question Professor Shine asked, is it fatty diarrhea?
No, sir.
How will you define steatorrhea? Fatty diarrhea is otherwise known as steatorrhea in our parlance. It is steatorrhea.
Yes, sir.
What is the definition of steatorrhea as per our books?
A pale, greasy, foul-smelling stool.
Greasy and foul smelling. Foul smelling is there for most of the stools, and the greasy can be for IBS also. Okay, it is copious or profuse diarrhea. Agreed that it is foul smelling. Generally floats on the top of water in the commode, no? Okay, that is a classic steatorrhea. That is profuse, frothy, foul smelling, and sometimes difficult to flush away from the closet. But in our chronic pancreatitis, which we see in Kerala or rest of country, it is not the classic steatorrhea. How will you differentiate that from this particular description of profuse, frothy, watery, etc. is for small bowel disease producing steatorrhea like celiac disease. In chronic pancreatitis, what will be the type of diarrhea?
Is it a maldigestion or a malabsorption?
Maldigestion.
What's the difference?
Maldigestion. Okay, so in the case of malabsorption, most of the fat is digested and it's available as smaller molecules, and carbohydrate is also split into smaller molecules, and that complex of fat, each molecule of digested fat, fatty acid, etc. will hold on to water, and also carbohydrates, because of mucosal disease, the carbohydrates also will be there, protein, amino acids will be there, everything will add to the molecular weight, and some carbohydrate will be fermented by bacteria that add to the gas, so that will be producing that sort of a picture. But in chronic pancreatitis, because of the exocrine pancreatic lipase deficiency, mostly, there is no digestion of fat. So practically the fat will come out through the other end undigested. So people will say greasy, oily stools. Sometimes oil dripping from the anus. Sometimes greasiness around the anus when they try to clean up after defecation. Some people even will be able to see the droplets of oil floating on the surface of water in the closet if they observe very well. Like the cooked oil, no, you will find brownish, reddish oil. That sort of oil also may come out through the other end. So that history is different. The state, unless and it is extremely severe sort of lipase deficiency.
One
and
point,
associated small bowel bacterial overgrowth due to diabetes, etc. But usually the steatorrhea due to maldigestion and malabsorption can be clinically differentiated. Over to you, Professor Shine.
yeah, as this inflammatory diarrhea, then how will it see mucus, as Sir has already said, presence of mucus doesn't mean that it is inflammatory diarrhea. But how will you diagnose inflammatory diarrhea from the history?
Presence of fever and joint pains.
And actually, blood and pus in the stool. Because the classical example is an inflammatory bowel disease. There you will have blood. There you will have pus.
Yeah, pus. Many patients.
So pus and blood, along with there will be fever, arthritis, arthralgia, or these are the things which will say that it is actually inflammatory diarrhea. Now,
there's a question about Jayanti ma'am asked about joint pains. Yeah. What the relevance of joint pain in a patient with a chronic diarrhea?
Well, diarrhea with joint pains can be seen in few diseases like celiac.
Any other disease?
A common pain.
IBD.
Pardon?
IBD.
Okay. Crohn's
Good.
disease.
IBD.
Agreed. Ulcerative colitis. Agreed. Okay.
Tropical sprue.
Tropical sprue joint manifestation unusual. You may get bone pains due to vitamin D deficiency or calcium deficiency in celiac as well as in tropical sprue, but not joint involvement is not that common.
Bipples.
Which is a condition?
Bipples is actually, arthritis is a very important. About 50 to 60% of them will have.
What are the conditions in which you get joint pain after acute diarrhea?
Shigella infection can.
What is that known as? What syndrome? Reiter syndrome. Arthropathy occurring after acute GI as well as urinary infection. It can happen after cystitis, urethritis, enteritis, colitis, etc. Reiter syndrome. Okay. I think the other two discussions are also not involved. I think we'll involve them also.
Yes, sir.
Yes.
Robert, sir.
Can you summarize once more? We have digressed a little bit.
A 34-year-old gentleman from Thrissur with no known comorbidities, non-alcoholic, presented with complaints of large volume, non-bloody diarrhea of 8 months duration with history of nocturnal episodes and associated periumbilical colicky abdominal pain with history of significant weight loss, anorexia and pedal edema with features of malabsorption.
Okay.
You have not mentioned about intestinal obstruction. So this patient is having a small bowel diarrhea with abdominal pain. So is it a partial obstruction? Is there any? I think in the diagnosis that should also come.
She has mentioned there is no abdominal distension, no vomiting in the earlier part.
But probably when you summarize, you can say that there is no evidence of intestinal obstruction.
Okay. Coming to the syndromic diagnosis, my syndromic diagnosis is chronic small bowel diarrhea without large bowel involvement with features of malabsorption and differentials or IBD, Crohn's.
I will catch you here. You said with or without. This is a diplomatic statement. So in examination, you cannot do like this. Okay. Small bowel diarrhea. That part is agreed. What is the evidence to say there is a large bowel involvement in this case? So you said with or without. So I will take the 50% with.
Frequency is less and patient is having mucus.
There is mucus in this. Okay, because there is mucus in the stools and the frequency is less. Okay, fine.
Can the rectal reservoir modify the findings? That may be valuable.
Pardon?
Rectal reservoir has modified the symptoms because large bowel, the rectum can modify the. Suppose there is a large effluent, still if the colon is intact, that may.
Okay, if mucus is there as an important symptom, I think why there is no mucus in small bowel diarrhea, Dr. Deepthi? Because mucus is there in the small bowel as well as large bowel. And you also said presence of blood in the stool is more in favor of large bowel and less in favor of small bowel. Because actually blood and mucus, all those things are there if you test by lab test. Because of the voluminous diarrhea, these things will be diluted. So you won't be able to observe it physically. The patient won't be able to observe these things physically because it is all diluted. When colonic type of diarrhea, they will be able to observe whether there is blood or mucus because the amount of fluid reaching the distal rectum will be much less, and therefore there's a less chance of dilution with the fluid. That is why you are seeing this as such. Okay. Okay, now IBD Crohn's. Points in favor.
Chronic diarrhea, small bowel diarrhea with the presence of painful diarrhea and features of malabsorption. Hello, sir.
Yeah, go ahead. See, IBD versus Crohn's. The diarrhea is more common in, IBD versus tuberculosis. These are differential diagnosis, no?
She has mentioned IBD. Second is infections, but
yeah, which infection? Which infection?
Infections causing malabsorption into giardiasis, cryptosporidium, strongyloidosis.
But which is a
parasite? Okay.
Yeah, that's parasites causing. No, when you say the immediate differential diagnosis of Crohn's, what is the immediate differential diagnosis? Definitely, it is tuberculosis. No? So, how do you differentiate between these two, history-wise?
History-wise, in TB, more constitutional symptoms will be there, sir.
Yeah. Fever, night sweats. Okay, good then.
How often TB presents with such severe diarrhea?
It's less common.
Unusual, no? It is said that. Okay, let me. Somebody is. Okay, I have cleared it. What are the morphological types of tuberculosis? Then you will understand. Now, in the interest of time, I will say ulcerative is rare. Ulceronodular is the most common. No, ulceroconstrictive. The pure ulcerative form is very rare, 15 to 20%, and only in such persons where you get diarrhea. In most of the patients, it will be abdominal pain, altered bowel habits, some little bit of diarrhea, constitutional syndromes, etc. Such severe form of diarrhea is very unusual. Don't you think, Professor Shine?
Yes, sir. What are the causes of diarrhea and tuberculosis? How tuberculosis? One is, as already said, it's ulceration. Then
Mechanisms. You are telling,
mechanism.
no?
Yeah,
Mechanisms of diarrhea in a case of tuberculosis or a Crohn's. Both you can say. These are the ways in which questions will come in the examination around the case. This is just to assess your depth of knowledge.
One is ulceration, and second is there can be altered bowel motility. Is it not? Okay.
Ulceration, producing exudation of pus, blood, everything. Okay.
Yeah, and then small. It may be associated with small intestinal bacterial overgrowth.
Yes.
Stasis. Yeah.
Stasis, and then can also cause lymphatic obstruction. They can have, so when there is a stricture, what will happen? There can be intestinal fistula.
Yes.
And then any other cause? Can it cause a bile acid malabsorption?
Sir,
Where is bile acid absorbed?
ileums.
Yeah, in the ileum. So what is the most common site of tuberculosis? Intestinal tuberculosis?
Ileocecal.
Ileocecum. So
region.
if the terminal ileum is involved, what will happen? It can also produce bile acid malabsorption, but it is more with Crohn's or TB. It's more with
Tuberculosis.
more with Crohn's actually, because extensive involvement.
Yeah. Tuberculosis, the involvement of the ileum is not that much. You have a lot of ileum left. But in Crohn's, as the process shines at no, the involvement is much more extensive.
Yes.
You have to be very clear about this. You are having doubts. So bile acid malabsorption is common in Crohn's and less common in TB. Be clear about it.
Can bowel tumors cause secreted diarrhea?
Sir, bowel
Tumors.
tumors. Yes, sir.
Which malignancy?
Carcinoid can cause. Ipsid can cause.
Ipsid can cause. Lymphoma of the small bowel can cause. But how it produces diarrhea? It produces a lymphatic obstruction of the small intestine, and also the lymphatic obstruction of the mesentery. So that can produce. So lymphoma can produce diarrhea. Okay. Then, as already sir has mentioned about the villus adenoma.
Right.
Which villus adenoma will produce the electrolyte disturbance? Is it proximal or distal? It is a distal one produces the electrolyte disturbance, not the proximal one. Okay, villus adenoma of the distal villus adenoma produces more secreted diarrhea. Even colonic malignancy can produce. Colonic malignancy can also produce. It can obstruct the bowel and produce diarrhea. You said about significant weight loss in this patient. So can you just from your differential diagnosis, which are the situations if there is a weight loss of 20 kg in this patient? So significant weight loss. Can you just give some reason for the significant weight loss?
Causes.
Yeah.
Crohn's with malabsorption can cause weight loss, significant weight loss.
Okay. Anything else?
Parasitic infections can cause.
Parasitic infections. Okay. What about lymph? Oh, go ahead.
Malignancy can cause.
Which malignancy? Again, small bowel lymphoma can produce. Ipsid can produce. Ipsid.
Yes.
Okay, malignancies can produce. Suppose a patient is having a celiac disease, and suddenly there is a significant weight loss. What are the differential diagnoses that will come to your mind?
We have to rule out malignancy, sir, and
EATL.
Enteropathy associated.
Enteropathy associated. And what are the complications of celiac disease? When the patient is on gluten-free diet, but they are not responding, what are those complications you expect? Ulcerative jejunouleitis. Have you heard about it? Ulcerative jejunouleitis, or they can develop a collagenous sprue. A collagen will form so that the absorption will be further reduced. Okay. What are the manifestations of IPSID? IPSID, what is the manifestation?
IPSID presents as
What is
intestinal
the
obstructions.
full form of IPSID? IPSID. What is IPSID?
Immunoproliferative
Immunoproliferative small intestinal disease. So one clue you got. This is in the small intestine. Okay,
Yes.
which part of small intestine? Usually.
jejunum.
Okay, correct. Is it focal or diffuse? It's a diffuse disease. Otherwise, a focal disease is unlikely to produce malabsorption.
Malabsorption, no? Yes.
So it's a diffuse mucosal involvement. Okay. And where in the world it is found most common? Which part of the world? Asia, Africa, Europe, America, Australia.
Okay.
Okay, I think the Mediterranean, that region, not very common disease. I have not seen a single case. Professor Shine, have you seen?
Actually, I have seen one case.
I might have seen it.
One case I have seen actually, sir. Very less.
Dr. George Curran told me that he has seen one case. Never as a student, he said he has seen a one case, but I have never seen a case of IPSID. Such a rare entity.
So from these differential diagnosis,
Professor Shine,
yes,
she has mentioned Crohn's infections. I think she said giardia. Then what all?
Cryptosporidium. Cryptosporidium strongyloidosis. Cryptosporidium, sir.
Cryptosporidiosis.
And
strongyloidosis.
Yes.
This cryptosporidium, strongyloids, and all. What is the usual history? Is it an immunocompromised patients or it is actually immunocompetent?
Compromised. Cryptosporidium is in immunocompromised patients.
Okay. In adults, okay.
Strongyloids.
Cryptosporidium generally in immunocompromised. Strongyloids.
Strongyloids.
Obviously, there may not be any immunological defect, but it still happens mostly in persons who have some sort of altered immunity. No. Tropical sprue I mentioned, but how will you define tropical sprue? What is tropical sprue?
Presence of after ruling out all other causes.
Okay, that is one of the methods of doing it, ruling out all other causes, and because the patient is in tropics. But it has to be a definition, no? It has to have.
Yes.
Okay, as per the definition, it's a chronic diarrheal disease characterized by malabsorption of two different type of nutrients. Okay, so one carbohydrate or protein or fat, not the same type. So two different types of nutrients, and which occurs in persons of residents of tropics or visitors to tropics. Okay, and then of course in the absence of any other identifiable etiology. So can this be tropical sprue?
Yes, sir.
Because he has obviously profound malabsorption and he is in tropics. So he is a resident.
Yes, sir.
But I think we have to rule out many things. We have to evaluate him thoroughly, and in the absence of other conditions, is there any specific histology for a tropical sprue by which you can confirm it? If you take a biopsy from the intestine, is there a specific, highly specific pathological appearance for tropical sprue? That itself is a topic. Small intestinal biopsy and diagnosis of various conditions. Some of the conditions can be diagnosed with a high degree of accuracy. Some of the conditions with moderate. Some conditions are non-specific findings. Okay, so that is also it's an examination question. Small bowel biopsy in the evaluation of chronic diarrhea. Okay, so you have to read up it thoroughly. Then eosinophilic gastroenteritis. I think whenever you entertain Crohn's or a similar disease, you can consider it, but it is mostly a histopathological entity. That's what I feel. It is unless there is, because tuberculosis can have a serosal component with peritonitis or TB peritonitis plus a mucosal component. Crohn's disease, it is very unusual to have these two components together. But eosinophilic enteritis, we can have a mucosal component or a muscular component as well as a serosal component. So the person can have ascites. In fact, patient may have present with not only ascites, pleural effusion, pericarditis, etc. And then they may have a mucosal component classically with ulceration and nodules or even strictures because there is involvement of the wall of the intestine. So, but unusual. This also I have seen only a couple of cases in the last many years. But what about you, Professor Stein? Eosinophilic enteritis, how often you find?
Yeah, it's not very common, but we have seen actually, sir.
Yeah, couple of just for mentioning, we may see one case per year or 2 cases per year maximum.
Eosinophilic esophagitis, I think it's also common in West actually. It's not
Western countries.
Yeah,
Okay.
in children, but eosinophilic esophagitis is little bit more common than adults actually.
I think in the evaluation of any case with the chronic diarrhea and weight loss, there is one more thing which you have to mention. It should not be 7th, it should be 4th or 3rd, etc. Any chronic diarrhea in your hospital and profound weight loss, you have to look for it because in the present scenario. And Jayanti ma'am has asked a question which probably was not answered. Behavior of the patient.
Yeah, high risk behavior. That is not mentioned. Behavior. Not mentioned in the history.
Yeah, that is very, very important. And unless you go and look for it, you may do all the investigations and still you may miss it out completely just for lack of doing this test, HIV test, and you are not aware of that entity. Okay, so HIV induced chronic diarrhea. In fact, that itself is a big question. HIV-induced diarrhea can be of many types. Heart-induced diarrhea, that also is there. So that itself is a big topic. But remember that any chronic diarrhea, weight loss, HIV has to be ruled out. It has to come close to the first 4 or so. Okay.
Yes.
You should also read about HIV enteropathy.
Okay.
Okay, I think we should ask the other two discussants also whether they have to add on anything. Dr. Bhavin? Dr. Bhavin, are you there?
Yes, sir. Good evening.
Have you have seen her list of differential diagnosis. Do you want to modify the list? Do you want to change the priority? You want to add on anything?
Sir, I would consider
because in the examination it's important to sort of tell the most important first, no? So prioritize the way in which you tell the diagnosis, not a list of diagnosis, not a theoretical list. We want a practical list based upon the clinical features, commonality of the condition in that locality. Okay, all those things should be there.
Sir, I would like to consider tuberculosis higher up, sir, along with IBD. IBD and tuberculosis as the initial differential.
The second will be tuberculosis, according to you.
Yes, sir.
Okay.
And the rest
Then,
is.
Will you not consider any of the condition? Do you want to consider any new condition?
No, sir.
Dr. Dheeraj?
HIV, which sir is already.
HIV, okay, that I already mentioned. That should be, HIV has to be mentioned in this case. In this scenario, if you don't mention HIV at all, the examiners can be very nasty. Okay, because that is such a common thing which has to be ruled out. Dr. Dheeraj, do you want to add on anything?
Same, sir. TB, then Crohn's, then celiac disease.
See, in the examination, you will be asked, how will you, what are the points in favor, what points against? Okay, so the maximum point should be for the disease which you put as a #1 diagnosis. And you should have the least points. That's the way.
He is having a contact of TB in family.
You think because he is okay, see, we said no, because diarrhea, chronic watery diarrhea is not a very common presentation of tuberculosis. Yes. It is as such around 15 to 20% of patients only present, that too in a person who is immunologically compromised. I have seen in persons who have open pulmonary tuberculosis, those who have altered immunity due to HIV, etc. I think much before they develop severe HIV-induced enteropathy, they may develop tuberculosis, etc. And then they may develop sort of ulcerative form. Because of this ulceroconstrictive factor is actually part of immunity. The purely ulcerative form is generally when the immunity is less. Thus, those patients may present with. Then we have some other list given: agammaglobulinemia, lymphangiectasia, A beta lipoproteinemia, Whipple's, etc., etc. Okay, that's a different thing. I think we will not digress. Over to Professor Shine for the further proceedings.
So they can go ahead, sir.
Yeah.
Any vasculitis you'll consider?
Yeah. If
vasculitis.
So, yeah, vasculitis. If so, which vasculitis?
See, basically the differentials will be a painful. No? It is a pain.
Pain is
diarrhea.
there. Pain is there.
It's a pain
Painful
with diarrhea. That's what it is. So basically, all the other ones which do not cause pain, all get excluded. No, the non-pain causing.
Giardia generally will not be much
Giardia,
pain.
strongyloid, all that
will not be pain. Celiac disease will not be with pain.
Yeah,
okay.
So basically you have to consider something that is transmural involvement, some ulcerative involvement, and vascular involvement. That will be your component of differential diagnosis. And in that context, why should they get a weight loss? If weight loss suggests that there should be some immune deficiency state, no? Because another interesting thing is, anorexia and weight loss will not start simultaneously with the abdominal pain. Something has to be started, and then the patient starts losing weight. So you have to keep that in context. Like Zollinger Ellison, they can have severe ulceration, they can present Zollinger Ellison, systemic mastocytosis. Some of these inflammatory conditions I think we should keep in mind as cause of diarrhea. Okay.
Some past history of peptic ulcer disease. What are the possibilities? Suppose if there is past history of peptic ulcer disease, what are the possibilities with diarrhea? Peptic ulcer disease with diarrhea.
If patient underwent any surgery in the past,
yeah,
post surgical diarrhea.
Post surgical. Anything else?
Ma'am just mentioned the name.
Zollinger Ellison syndrome. Anything else? Mastocytosis. So when you previous history of peptic ulcer disease, these things should come to your mind.
Okay.
Thyroid disease.
Hyperthyroidism.
Hyperthyroidism. Medullary carcinoma. Medullary carcinoma, thyroid. Previous history of any pancreatic disease also important. Why?
You may be discussed, no? Only pancreatic section. All those.
So all these things should come in the past history. Okay.
Okay.
You don't have to go to the extreme degree. No history of peptic ulcer surgery, no history of pancreatic surgery, etc. Then there is no prior surgery.
Yes, sir.
Because if you go into the depth, the
post radiation. Yes, madam.
Sometimes
yes.
May appreciate, sometimes may get annoyed.
Okay.
Can we proceed further?
Yes, sir. Coming to general physical examination, patient is ill-nourished, grossly emaciated, well-oriented to time, place, and person. Vitals: BP 60/50 mm, Hg right arm, pallor present, no icterus cyanosis, clubbing or lymphadenopathy, bilateral pitting pedal edema present, and JVP is normal.
How will you assess the nutritional status of a patient?
BMI, mid-arm circumference mentioned.
In this patient, any BMI problem?
Yes, sir. 13.1. Sir.
You have to do the corrected BMI. What is corrected BMI? Because he has edema, no? Profound pedal edema. Yes, so it's part of the weight will be due to water retention. Dr. Dheeraj, what is corrected BMI? Babin, do you know how to correct the BMI if there is pedal edema?
So for pedal edema, we reduce the body weight by 5% and take that as a corrected body weight.
Okay, fine.
And for ascites, 5% for mild, moderate, and severe ascites.
Okay. So when there is edema, the BMI may be fallaciously high, and the patient might have lost weight, but BMI may be normal, and we may make an erroneous impression on the basis of BMI. Okay, one has to be very careful.
Okay. And positive findings include he has glossitis, cheilitis, oral ulcers present, and loss of buccal fat, thinning of upper arms noted. Nutritional assessment, BMI is 13.1, tricep skin fold thickness is below 1.7, mid-arm circumference 18 centimeters, and hand grip is 29. Coming to systemic examination,
What about clubbing? Importance of clubbing? If suppose clubbing is there, what are the possibilities that will come to your mind?
So celiac disease and IPSID will have clubbing.
IPSID, celiac disease. Can tuberculosis produce a clubbing?
Not sure.
In presence of complications, especially lung complications like bronchiectasis, lung abscess. So isolated tuberculosis involvement of the gut will not produce a clubbing. But if there is associated complications like bronchiectasis or lung abscess, then they can develop clubbing. As you rightly said, IPSID and lymphoma. Okay, go ahead.
Dheeraj, what's your comment on the low blood pressure? 60 by 50.
Due to fluid.
Dheeraj?
Yes, ma'am. Due to
What are the
hypovolemia.
possibilities? What are the possibilities? Hypertension.
Hypovolemia. One is.
Anything else?
Adrenal insufficiency.
1 minute now. Let them answer.
Adrenal insufficiency, ma'am.
What is it? What are the things you look for adrenal insufficiency in general examination?
Like Addison's disease, like hyperpigmentation. Hyperpigmentation.
Where?
Then.
Where will you look for hyperpigmentation? Yeah. For one question, you have to ask another 3 questions. Where will you look for hyperpigmentation? What are the conditions you can get macro pigmentation and palmar pigmentation in a case for chronic diarrhea?
B12 deficiencies will get.
These are the most important findings that you should look for. Yeah.
Yes, ma'am.
Where will you look for pigmentation and Addison's?
Now, can you be a little louder?
Where will you look for hyperpigmentation and Addison's?
Or the face and trunk.
Where else will you look for? These are the findings that has been focused in this particular patient, you know.
Yes, ma'am.
Now, icterus and all is not relevant at all.
Which condition you get palmar crease hyperpigmentation? Oral cavity, palmar crease. In which condition you get knuckle hyperpigmentation? I think people forgot our general examination.
General examination is forgotten, exactly. Yeah.
We will come back with the one class on that again. Okay, read up for everyone.
Okay.
In the interest of time, we will proceed now.
On inspection,
nothing positive, just move on.
plankfulness is present.
Anything positive?
Inspection, plankfulness is present. Palpation, mild diffuse tenderness and percussion normal. Shifting dullness present.
Shifting dullness is there. Ascites is there. No mass, nothing.
No, sir. No, sir.
Okay. So, rectal examination?
Rectal examination normal and other systems normal.
In the central nervous system, you said focal neurological deficit. What actually you should have looked at?
You should person who consumes alcohol. You have to do a complete detailed CNS examination. Right from higher function, right up to the reflexes and gait.
Okay. Alcohol use disorder, you have to be careful. And chronic diarrhea, malabsorption, also vitamin B deficiencies, B12. They can have posterior column deficits and ataxia, vibration sense, all those may be affected. That may be very subtle and patient may not complain at all. Okay. So mentioning those things may add more points for you.
Okay.
But don't go into the very detailed, a mini neuro examination would be ideal.
Okay.
After your examination, you found that ascites is there.
Yes, sir.
So then what is your order of your differential diagnosis?
Tuberculosis can present as ascites.
Crohn's, usually ascites is not a manifestation. Any other?
Eosinophilic gastroenteritis can.
Yeah. Then other conditions where you get ascites, pleural effusion, chylous ascites, with malabsorption.
Lymphangiectasia.
Yeah, lymphangiectasia. If it is involving the serosa. Okay. Then Okay, then go ahead. So after the examination, what is the order of different diagnosis you mentioned, and now we can we go ahead?
I think we can ask Dr. Bhavin to how will they plan the investigation?
Okay.
Very fast. No, don't show this. The other thing, he has to tell what is the line, the way in which they will investigate in this case. We can mention all the tests, but there has to be an order and there has to be a reason why we are going to do that test. What we expect also.
Sir, in blood investigation, sir, I will start with a complete hemogram, sir, because the patient has had pallor, sir, to look for anemia and platelet count in ESR, sir. Then I will like to do for liver function test.
Is there any relevance for this, or it's a completion sake?
Sir, complete blood count, sir.
So the hemoglobin, a low hemoglobin will give you what clue?
Sir, the patient has a nutritional anemia, sir, or a blood loss, either a blood loss or.
Okay, so there can be anemia due to blood loss or nutritional deficiency of various types. And depending upon the MCV or peripheral smear, you will try to arrive at a correct diagnosis. Then leukocytes.
Leukocytes are in case of inflammatory diarrhea or infectious diarrhea. The leukocyte count.
This is a chronic diarrhea, no?
Yes, sir.
Okay.
Can you get low WBC?
That was my aim of asking the question.
Yes, sir.
This condition you get a low WBC and chronic diarrhea.
Sir, immunodeficiency states we can get, sir.
So, yeah.
Okay, which immunodeficiency? In lymphangiectasia also can happen.
Low lymphocyte count and lymphangiectasia, low WBC count in
and lymphocytes.
B12 deficiency and folate deficiency.
Okay, sir.
LFT, what do you want to look specifically?
From the peripheral smear, can you make a diagnosis?
Yeah, peripheral smear. Peripheral smear. What do you want to see?
Peripheral smear, sir. I want to look at the RBC morphology, sir, to look for iron and B12.
Pardon? RBC morphology to look for?
RBC morphology. Either iron deficiency or B12 deficiency.
Okay, agreed. So usual one is iron deficiency or B12 deficiency, microcytic or dimorphic. Anything specific by which we can diagnose the disease by looking at the peripheral smear.
Sir, in A beta lipoproteinemia, we can.
What will be the picture?
What will you find?
What will be the blood picture and what's
acanthocytes?
Pardon?
Acanthocytes.
Acanthocytes.
Okay.
Good.
Acanthocytes.
Acanthocytes. I think acanthocytes will be spiky, spiny RBCs.
Yes.
So in LFT, what do you want to specifically look?
I want to look at protein level, sir, because the patient has a peripheral edema, sir, to look for albumin and total protein levels.
Okay.
In case of protein losing enteropathy, they will have low protein level.
Okay, you looked at the albumin. Albumin is low. You looked at the globulin. Is it relevant? Globulin?
Sir, both albumin and globulin are low in case of protein losing enteropathy.
In case of?
Protein losing enteropathy, sir. We can get.
Albumin and globulin can be low. Okay. Albumin is mildly diminished. Globulin is significantly diminished.
So this can be seen in immunodeficiency states, sir, combined variable
hypogamma-globulin. Okay.
IgA deficiency.
What about alkaline phosphatase? If it is low, what does it mean? Zinc deficiency.
I'm not sure.
Zinc deficiency. ALP is low. It is increased in calcium or vitamin D.
No, because these people have osteomalacia and vitamin D, calcium metabolism abnormalities, no?
Yeah.
So we can expect abnormal.
Cholesterol level, what is the significance? Cholesterol?
The cholesterol level will be low in nutritional in malabsorption state, sir.
Specifically, low cholesterol in?
in lymphangiectasia.
Lymphangiectasia and abetal hypolipoproteinemia. Have you heard about citrulline? What is the significance of citrulline?
Citrulline is an amino acid, sir. I don't know.
Actually, citrulline, the level of citrulline correlates with the mucosal integrity. See, suppose if there is a resection of the bowel, intestinal resection, and it's one of the situations where when you decide about the small bowel transplant, so when citrulline level is high, it's adequate, that indicates that the remaining bowel is adequate because there is no short bowel syndrome. Okay. And it will be low in extensive small bowel resection. What's the role of ANA?
Sir, ANA in various type of autoimmune diseases, like vasculitis, which we are considering here, the ANA levels will be positive.
Which vasculitis will produce malabsorption?
Sir, vasculitis, like sir, SLE can produce a small vessel vasculitis.
Yes. Systemic sclerosis.
Systemic sclerosis.
Okay.
I think, what is the role of stool examination? Dr. Dheeraj?
Sir, we will look for ova and cysts, sir.
Okay, macroscopy also will help you, one can actually, if in the ward, one can act in KMC and all where we were doing malabsorption studies. One of the method is to look at the stool because the patient will tell many things. We have no idea what exactly happening. So
if the stool is oily and sticky,
you will have some idea. Okay, you can reconfirm what the patient says. Then what test you do?
Why fresh samples? Sorry, sir. Why fresh samples? What's the advantage of checking a fresh sample?
Why do you need a stool fresh sample to do a lab test? Why can't you do keep it overnight in the fridge and or some other place in the lab and do it next day?
Which are the parasites you pick up with the fresh stool sample?
In acute diarrhea, it is different. In chronic diarrhea, it is different. Some of the parasites are identified, the trophozoites are identified because of its mobility.
Yeah.
In a fresh sample. For example, in acute diarrhea, EH trophocyte, Endoamoeba histolytica trophocyte is identified by its mobility and by its RBCs present inside in the cytoplasm because it's phagocytic, but it's an acute diarrhea. In a chronic diarrhea, the parasite which you look for is generally Giardia. Giardia. And so Giardia ideally should be taken from the genital fluid or in a diarrheal situation fresh sample, you may find it. What is the microscopic appearance of a Giardia lamblia trophocyte?
What does it appear like?
If you stand under a banyan tree or a fig tree, the leaves will fall and you have a mild breeze, it sort of undulate. The leaves will not fall straight away like a mango or coconut. It will undulate in the air and come. That is not a falling leaf pattern. And immediate differential diagnosis is actually another parasite, Trichomona vaginalis, which can contaminate the stool specimen, especially females. So that movement will be fast. We call it a bandicoot movement. The big rat, bandicoot. It will move very fast. That sort of a movement is there. But the Giardia, it will be a falling leaf. And interestingly, I would like to say that for my theory in DM, the question paper was ultra structure of Giardia lamblia. So you can expect any type of such funny questions. Ultra structure of Giardia lamblia. And I had a real tough time. I have just read it once. Okay. So you must have at least some mental picture how it looks like. The shape is like a tennis racket. So today or tomorrow, you please look at your textbook and try to look at the shape of it. If you are shown a picture in an OSCE, you must be able to identify it. Okay.
Would you like to do calprotectin?
Yes, ma'am.
I think I will do a class on stool examination subsequently so that everyone will be aware.
You have to be fast with your investigations. No, just tell quickly what are the investigations you want to discuss.
So
Can move
Stool
on.
routine, you said OS parasite. Dheeraj, what else?
Um,
Any, any special stain you use?
Shift stain.
Ship stain.
Okay, for fat.
Fat.
Acid.
Sudan.
Fat.
Sudan stain.
Sudan stain.
Yeah.
Then you have
So,
the
Sudan staining for
modified
fat
acid pass.
globules. Okay. So in a chronic diarrhea in a child, you look for the pH and then reducing substances. If there is a carbohydrate malabsorption, especially disaccharide malabsorption like lactose intolerance. Okay. So look for the stool pH as well as stool
Osmolality.
Yes,
Okay.
stool fat. What is the disadvantage of Van de Kamer test? It's a cumbersome, I know. What are the other? See, what are the fats in the stool usually?
What is it that you identify?
What's the fat in the stool? Triglyceride.
So the fat which we eat is as in which form?
Long chain.
Usually
Triglycerides.
Triglycerides. Okay.
Triglycerides.
Triglycerides, diglycerides, monoglycerides, free fatty acids, and also sterols are there. Sterols. So the one of the disadvantages with Van de Kamer is actually they are not going to check this sterols. Fecal sterols are not checked in Van de Kamer. And another thing is the medium chain triglycerides are completely missed. If the patient is on medium chain triglyceride, it will be missed. When you say it is a positive Sudan 3 test, how many droplets in the high power field?
40, sir.
What is this reference 40? Where did you get this reference 40? So two things you look for. One is the number and the size of the fat globule. More than 50 and the size of the globule more than the size of an RBC, that is 7.2 micron per high power field. Some say 100, some say 50. Some chapters will find is 50, some chapters 100. One is the number as well as the size of the fat globule.
Yes,
and important is we'll ask for special stain, for cryptosporidiasis and placement and all those other parasites. You have to ask for the special AFB stain. You must know what's the concentration of acid that is loose. All these are the Viva questions. I think we should move on, no? It's already 9:25.
Yes. Okay.
9:25.
Okay, there are many tests in the stools. Okay, we'll leave it for the time being. So, back to Dr. Bhavin. Interpret fast.
I need to mention about a combined variable. No, you have to ask the electrophoresis, immunoglobulin profile. You suspected immunosuppressed state. You have to be very fast in answering, and have a way of answering. No, when you mention, you have to IgG, IgM, IgA. That will come as important duty in this patient. So have a system of first will be CBC, then you have to do a stool examination will be level 2. And then you come to the biochemistry. You have to look for serum electrolytes, you have to look for additions, you have to look for serum cortisol. All these investigations have to be highlighted immediately. Blood sugar, serum creatinine, all these have to come, with the rattle out fast. And so special investigations would be, before they go on, special investigations would be, they ask the what are the other things you ask for? What would be the diagnostic investigation of this patient that you were asked? What would be the diagnostic test?
Diagnostic test in the stool examination.
Not the stool, in general.
Colonoscopy.
Colonoscopy in this patient. You'll ask for colonoscopy of the small bowel diarrhea. You'll ask for colonoscopy. You'll ask for a biopsy, judgmental biopsy or a dural. That will give you at least some clue what it is. So my level 1 would be IgG, IgA, IgM, and then go straight for a dural biopsy with a jejunal aspirate of the listing for parasites. And all your imaging will all be only for structural changes. It may not give you a clue to the etiology. Okay, can you just move on? Can you just read out?
Yes, ma'am. In the investigations, hemoglobin is 9.8, WBC count 10,000, MCV 73, and ferritin is 27. So this looks like iron deficiency anemia. Normal vitamin B12 levels. CRP is 0.6. Urine routine examination is showing 12 to 15 pus cells with 1 to 2 RBCs. Anti-TTG is normal, amylase is normal, IgA levels are normal. HIV is negative.
Next one, Deepthi.
Yes.
Urea 10, creatinine 0.5. Total protein is low, both albumin as well as globulin are low. Bilirubin is normal, the other enzymes are normal. electrolytes are deranged, low sodium, low potassium, and low magnesium levels. Stool routine examination, 1 to 2 RBCs are seen, sir. Cysts for entamoeba histolytica are present. Stool culture is negative, occult blood is negative. No pus
Okay,
cells.
stools, EH cyst is present. So what is the relevance, Dr. Dheeraj?
Amoebic colitis can be one possibility.
But did we diagnose amoebic colitis from the history?
No,
Is the
small
history
bowel
like a
diarrhea.
colitis?
no, sir.
Because many people will be carriers of EH, and when they have diarrhea, a lot of cyst will be there in the stool. Okay. So presence of cyst generally does not mean they are having active disease due to amoeba. It is due to something else.
Carriers.
They are carriers. Okay. The colonoscopy finding, go back, Dr. Deepthi. Ileum showed healed ulcer, cecum and ileocecal valve edematous, rest of the colon normal, OGD scopy normal.
Would you take a biopsy? So what was a biopsy? Why did you take a biopsy in a normal colon?
Microscopic colitis to rule out.
Yeah, you have to take, so it's right-sided. So you always ask for a right-sided colonic biopsy. And OGD, would you just pass off with a OGD or would you ask for a biopsy again?
D2 biopsy we will ask.
You have to ask for a deep biopsy. You go up to D3, D4 and take biopsies, place it in a properly aligned tissue paper and then put it into the bottle. All these questions will be asked. You cannot just take with a needle and tease it out and push it in.
Which is the ideal site to take biopsy in the celiac disease? And then tropical sprue, what's the difference?
Celiac disease or D2 biopsy.
Yeah, D2, D3 biopsy, and also you can take a duodenal bulb.
What is
D1? If you take D1, what are the problems in taking a D1 biopsy? The architectural distortion because of the Brunner's gland. There can be gastric heterotropia. So there are multiple issues in that, but still you should take a duodenal bulb biopsy. But what about tropical sprue?
Tropical sprue, sir, will take a deeper biopsy. Sir.
Yeah, third and fourth part of duodenum. What about Whipple's? You have to take duodenum, jejunum as deep as possible. Okay. Can you get scalloping in other conditions? You know that it is in the celiac disease, but scalloping can be seen in other situations.
I'm not aware of others.
Eosinophilic enteritis, giardiasis, amyloidosis, tropical sprue, even HIV enteropathy, all these things can. So it is not specific for celiac disease.
What is
the biopsy finding in common variable immunodeficiency? Common variable immunodeficiency, what is a biopsy finding?
What is the submucosa of the intestine usually containing? What cell? Which cell?
So it will be contain lymphocytes, lymphoid follicles
and plasma cells, no?
There is positive plasma cells in the lamina propria. The lymphocyte count will be normal. Okay. So you can get a lymphoid aggregates and even in intraepithelial lymphocytes can be seen. And this is another situation where you get a granuloma in the lamina propria. Basically, absence of plasma cells or positive plasma cells with the normal lymphocytes. Okay. How will you move forward now?
Wait for the biopsy. We'll ask for the biopsy. Okay.
Biopsy.
The biopsy ileum shows a moderate chronic inflammation with focal flattening of villi. cecum is showing acute and chronic inflammation with crypt abscess. Body part of a nematode parasite was seen. Strongyloids or trichuris trichuria to be considered. Rectum showed mild chronic inflammation.
Okay, now some parasite was seen in the cecum. Okay, strongyloids usually is more seen in small intestine. Though in severe infection, it can affect any part of the body, including up to brain it may go. But usually, okay, unless it is an invasive, very severe super infection. And trichuris trichura bialad
Muscle biopsy only.
in the colon. In the colon. Okay. Do we have the picture? Do we have the picture, Dr. Deepthi? Sometimes this picture will be shown and you will be asked to make a diagnosis. Okay. That is the area?
Yes, sir.
That's the
Body
area.
part. Yes. This is stool examination, sir. Larvae or seed.
You saw found larvae?
And this is eggs.
The eggs are typical that of Trichuris trichuria. Trichuris trichuria, that is the way it should be pronounced. Okay, the eggs are suggestive but not typical because the terminal mucus plugs are not seen. Because there are mucus plugs sort of thing on either side, like a peck-shaped thing, which seems to be missing. So it is not a typical Trichuris trichuria. Strongyloids, you don't find like that. Strongyloids, it is rounded over. That is my knowledge. And usually you may find larva in fresh samples of strongyloids. And jejunal aspirate also may find larva as well as the ova. Okay. So
the strongyloids, we can also get it from the duodenal and gastric biopsy.
Biopsies also.
We have actually published one case of gastric outlet obstruction, and the patient was treated with ivermectin and the outlet obstruction gone due to strongyloids.
Yeah. Strongyloids are notorious to produce not only diarrhea, but upper GI obstruction. We also published an article of upper GI obstruction, jejunal obstruction due to strongyloid stricture. And interestingly, it gets reversed completely on treatment. That's one thing. It's a reversible sort of a stricture. It's an inflammatory stricture which gets reversed on treatment, strongyloidiasis. Okay. Now the stool shows some parasites. Nearest is Trichuris trichura. Okay. But what will be the morphological appearance of Trichuris trichura, or otherwise known as bookworm? Because most of you people are little weak on parasitology. Trichuris trichura generally can produce colonic type of diarrhea, mucus diarrhea, and in children it can produce profound protein-losing enteropathy. They can present with a rectal collapse in malnourished children. Okay, so in children, profound malnutrition, hypoalbuminemia, chronic diarrhea. In adults, chronic diarrhea, mucus diarrhea. On colonoscopy, you will find the colon sort of studded with multiple worms. The entire colon will be sort of studded with multiple worms. You can pull out this. You will find it is attached to the mucosa with sort of another part. Okay. And when you examine it on a slide, you will find it has got a handle and a book-like appearance. That is why it is called a bookworm. And when you find a worm, if you are not able to identify, there are two methods. Send it to microbiology. That will be the easiest. But if you have more worms, you can actually crush it under another cover slip and examine under microscope, because most of us know how to identify the ova of the worms. Okay, this I learned from my professor. So if you don't know to identify the worm, try to identify the worm by seeing the ova. But if you only one worm identified, send it to microbiology, because we may destroy the worm by crushing it. Okay, so these are the two methods of identifying it. And there are other serology tests by which you can confirm various parasitic infestation as well. Okay, so in this case, and in Trichuris trichura, therefore, it has to be in the colon, and it's very unusual to find it in the small intestine, and very unusual to produce the classic type of malabsorption. Here we have not done any decylose or fecal fat test, so we don't know. But patient has profound protein-losing enteropathy, which is consistent with the Trichuris trichura, but not in an adult. That finding is in a strongyloids. You don't find it on a gross examination on colonoscopy or on a endoscopy. It's a microscopic worm. So it is possible the person may be having a very serious strongyloid infection, but the ova is not like that. So there are atypicalities. The ova is not that of a strongyloid, and you have gone.
Audible, sir. Audible.
For patient's sake, Dr. Deep's connection would have gone. This was discussed with the microbiologist of Ambila. Dr. Robert, can you just chip in the information?
I think our pathologist had discussed with the microbiologist, and they found out that it was Capillaria philippinensis. That is our organism producing the symptom. Patient was treated with mebendazole and albendazole, and patient improved with remarkably. And all his edema, aside everything disappeared and regained his normal health.
And this is actually due to his habit of eating street food and that to oysters.
He was taking
mussels, no? Seafood and this lake food and all those things. And a couple of cases have been described, I think, near Trichur, Kerala, where people are fond of eating seafood and lake food, freshwater fish, and I think it is from mussels.
I think the birds are playing a role in this. Birds are playing a role in the transmission.
So do you think it's the migratory birds which are bringing this?
Probably, because they are droppings in the sea, in the water, backwaters, and the fish is ingesting it, and the people are eating the fish.
Improperly cooked. That's another thing. If it is properly cooked, perhaps it doesn't happen. I think improperly cooked. I think this was described in around Philippines, no? Capillaria philippinensis.
That was the initial name.
And then it produced, but nowadays in other parts of the world also.
It's coming. So the name they have changed to paracapillins.
Now it is called paracapillariasis. Something like that. What is the full name? Paracapillariasis.
Philippinensis. Paracapillariasis. That's the name.
So this is a very rare case, but don't go and say it in the examination. When you are about to exhaust the list, perhaps we can say capillariasis because it's uncommon. But strongyloidiasis and giardiasis, cryptosporidiosis, all those things should be more common and than capillariasis because it's such a rare thing. Okay. Any comments, Dr. Shine?
It was a very interesting case, sir, actually.
Actually, it was the CPC kept for the last ISG.
ISG.
Last ISG. In itself, I booked the case and I asked for the slides because it's an interesting case of chronic diarrhea malabsorption. And it's not for the final diagnosis, but for the total presentation. How a small bowel diarrhea can present and produce a profound malabsorption, hypoproteinemia, and all those things. And how the biopsy helps, the role of biopsy. Usually in a diarrhea malabsorption, it is the deep duodenal biopsy which helps us. But in this case, it was the, I think, ileal biopsy which helped us. Andy, ma'am?
Yeah, I think that normally we discuss 4 parasites, no, that cause small bowel diarrhea. So that Capillaria philippinensis, this comes in as one of the BDs. Giardia, Strongy, Cryptosporidiasis, and Capillaria philippinensis. These are the 4. So Capillaria philippinensis usually duodenal biopsy, Cryptosporidia also all can be picked up on a duodenal biopsy. Giardia, everything can be picked up on a. You have a good duodenal biopsy, it's more diagnostic than a colonic biopsy. It's one of the causes of malabsorption.
One thing ma'am mentioned, I think, but whether you really understood orientation. When you take a deep duodenal biopsy, you must know you have to actually put it on a wet filter paper and orient it properly so that the cut surface is facing you, and then you touch onto the other side of the filter paper. Okay. So when we were doing our DM, Jayanti ma'am and myself, and perhaps Dr. Shine, Dr. Robert also, we were doing deep biopsy by Crosby capsule, by passing a capsule into the jejunum and making sure that it reaches the jejunum because it crosses the spine twice. Once when it crosses into the antrum and pylorus, and second when it goes to the DJ flexure. So make sure that there is a loop like that. It crosses the spine twice, and then we take a biopsy from outside by firing a sort of syringe And it's a very cumbersome sort of assembly, and the person on night duty is supposed to sort of arrange it and keep it ready and do and pass the tube and then make sure that the screening is done. Jayanti ma'am, you would have done many, I have done many, and others also have done many, but I think it's a part of history now.
The importance of alignment, I think you should know, is because of Willis strip ratio that you have to assess in all these cases. So that's one of the reasons. If you just tease it along with the needle and just drop it into the bottle, then you'll just get cross sections of the Willis strip, which is not the aim in a case of malabsorption. In malabsorption, what you want to know is what's the Willis strip ratio. Whether it's 3 to 4:1, or it's a reversal, you have to get the Marsh criteria. So these are the reasons why we ask for a alignment. I mean, we do see nowadays you just tease it with your needle and just drop it into the bottle and you leave the pathologist to align it, which is not possible because it's done by the technician. So what's very important is that you align. Very nice case. I think learning points are, I think, the history taking. Very important that that mucus bit should be, you have to mask it a bit. A person will not be able to say watery diarrhea, where is he going to go and see the mucus there? In that watery diarrhea, to pick up a mucus, and that too in the Western closet. I think those are things that in the exam, no one is going to ask, the patient, did you have mucus? And go and ask the candidate, did you pass mucus? It is a small bowel diarrhea, it is a chronic diarrhea, it is a malabsorption diarrhea, and focus your attention to that and don't bring in a mucus there and say it is a combination. You will lose your foothold on the case. Absolutely just lose your foothold. And that's something. And then once you get there to small bowel diarrhea, first and foremost is it osmotic? Is it secretory? Try to see if the person is not eating food and he gets control, then you know it's osmotic. Then once you get that as watery diarrhea, it's not osmotic, it is more of secretory, then your differentials will go towards the secretory diarrhea. And there you just have only three, you have bloody diarrhea, the inflammatory diarrhea, and you have the watery diarrhea. In the watery, it will be secretory and osmotic. And then to me, it is only painful and painless. That's all. So have your differentials for painful and differentials for painless. And in a patient's consuming alcohol, immune deficiency state has to be kept in mind. You have to look for addisons. These are some of the things that you have to keep in mind. The DD will essentially be recurrent abdominal pain with diarrhea. That's it. Those will be a differential. So your celiac disease, tropical flu, all that will all go. But in an immune deficient state, yes, parasites will come as a DD. And then as all our faculty members described, like you have strongyloid with abdominal pain. That means parasites can cause abdominal pain, recurrent abdominal pain. Roundworm will cause, strongy can cause. So I think your focus of attention should be abdominal pain with chronic diarrhea. That's a focus in this particular case. If you put mucus, then the entire discussion goes towards mucus. This is a goblet cells produce mucus. It's a normal finding in any bowel, any stool. Okay, so these are some of the points I think which I would like to highlight. And otherwise, the case was excellent.
Okay, Professor Shine, any further comments to make?
Nothing, sir. Thank you.
Okay, Dr. Srividhi, are you there? I want to thank Dr. Deepthi for presenting the case and Dr. Robert for providing us the case material. And thank Dr. Bhavin and Dr. Dheeraj for joining us for the discussion. On behalf of ISG Kerala chapter, I want to thank Dr. Shine Sadashivan for his class. He has prepared the class very well and he has taken a wonderful class. Thank you very much from the bottom of my heart. And I want to thank Dr. Robert Panikkal for joining as co-faculty and Jayanti ma'am, as usual, with a lot of pearls of wisdom. Okay, we look forward to further such classes and comments from all of you. And with these words, I conclude the class. Good night to all of you.
Next session will be on Thursday. Okay.
Next session will be next Thursday.
That is second
next
and
week
fourth
Thursday.
Saturday
Next week Thursday, 8:30, no?
At 8:30, yeah.
8:30. Okay. Thank you. Thank you very much. Good night.
Good night. Good night.
Good night.
Thank you, ma'am. Thank you, sir.